Welcome to our luncheon symposium this afternoon. The title of the lunch symposium is Identifying and Overcoming Hurdles in Treatment of Chronic Antibody-Mediated Rejection, and this is sponsored by CSL Behring. And on behalf of the AST, I'd like to thank CSL Behring for their continued support of the CEoT meeting. Today's moderators are Deb Adey from the University of California in San Francisco and Annette Tambur from Northwestern. And I'd like to welcome the first speaker, Dr. A.J. Israni from Hennepin County Medical Center, to the podium to give the first presentation.
All right. Thank you all for coming, and thank you to the organizers for the opportunity to present some of our data. And the topic is incidence and prevalence of CAMR. Do we really know? So these are my conflicts of interest. I have received grant funding from CSL Behring and been on the advisory board. My presentation does not include discussion of off-label investigational use products. Okay, so this is the outline of my talk. I'll be talking about the challenges in knowing the true prevalence of CAMR. And I'll be presenting data from DCAF study, that's Deterioration of Kidney Allograft Function study. It's a multi-center cohort. I'll describe that cohort to you. And then I'll talk about DCAF and data that was merged with the USRDS claims data. So we consented a subset of these patients to allow us to link their data with USRDS claims data. So these are Medicare, they have Medicare primary coverage. Next, I'll describe to you the risk factors from that study in terms of risk factors that contribute to development of antibody-mediated rejection. And then last thing, I'll propose methods to enhance capturing CAMR before it's too late. And just talk a little bit about sort of how you can manage these patients and in terms of monitoring for CAMR. Okay, so first I'll talk about assessing AMR incidence. So DCAF study is a 7-center study, multi-center cohort. There was a cross-sectional cohort, but today I'll just talk about data from the prospective arm, which included 7 centers, 2 in Canada, so University of Alberta and Winnipeg, and 5 in the US. So we had University of Minnesota, Hennepin Healthcare, Mayo Clinic, University of Iowa, and UAB. And those are the 7 centers that made up DCAF. We enrolled patients who were transplanted between 2005 to 2011 from the time of transplant. And a subset of these patients were part of DCAF genomics, and most of the data I'll show you actually is from that subset. So it included 6 centers. Winnipeg was not one of those centers. That was from DCAF that was included in genomics, so the rest of the centers also participated in genomic study. And in that cohort, we had 194 AMRs, so about 6.2% over 4.85 years of follow-up, and the cohort was 3,131 patients. And the publication here describes this data, and it was published in Clinical Transplantation in 2021. So interestingly, the time to first AMR was 0.97 years, plus minus 1.17 years. So you can see on this figure here that you're starting to see patients develop AMR actually within the first 3 months post-transplant. So then you start to think about, okay, so what are the things that might be causing that? And things that immediately come to mind is there's probably some preformed antibodies there that were present in those patients. Okay, so we looked at the pathology findings. So these are the local pathologists at the treating centers, and they looked at their findings on that first AMR that I described in the previous slide. So the pathologists were finding that about 60% of the patients had AMR only on biopsies, and 37.6% were having AMR mixed with TCMR. And about 2.6 biopsies, the way they were read, was unknown whether there was concurrent TCMR present or not. So what happens to these AMR patients? So 22 or 11.3% had at least one subsequent AMR. So they had another biopsy which was diagnosed as AMR. Another 15 or 7.7% had a subsequent biopsy which showed TCMR. But what's most concerning is that 67 or 34.5% had debt-censored graft failure. So, it's again, what we all recognize is that AMR is a major problem for our patients. Unfortunately, at that time, we were not classifying AMR as chronic AMR or not, and so this is kind of the data that we have available from this cohort. But what was sort of daunting was the association of AMR was associated with a 10-fold higher risk of debt-censored graft failure compared to the patients that did not have AMR. So the adjusted hazard ratio was 10.6, and you can see that confidence interval of 6.8 to 16.5, and the p-value was quite significant at 0.01. So again, we are at least able to find the AMR diagnoses in these cohort studies, and we know that this is a pretty bad prognostic feature. And as I showed you, we were seeing a fair amount of AMR in the first 90 days. So we broke out 194 biopsies, 86 within the first 90 days. We called it early AMR, and the 108 subsequent ones that occurred after 90 days were late AMR. And early and late AMR were associated with 4.8 and nearly 20-fold increase in debt-censored graft failure. So early AMR, the adjusted hazard ratio is 4.8, and late AMR, the adjusted hazard ratio is 24. Again, both of these are significant. So regardless of whether you have early or late, it is, again, a really bad prognostic feature. The late AMRs are much more concerning. The early AMRs, again, you start to think about preformed antibodies at the time of transplant. So what were the risk factors that we saw in our cohort study? We did multivariate modeling. These were the risk factors that were significant with the p-value of 0.05. Younger recipient age was a risk factor. More HLA-DR mismatching was a risk factor. High PRA was a risk factor. If you had a T or B cell crossmatch at the time of transplant was a risk factor. And delayed graft function was also a risk factor. So these were independent risk factors for AMR. Then the next thing we said is, okay, it's hard to figure out the frequency of this. Can we use some claims data to see maybe there's a pattern of claims that would help us, diagnose at least or get to the incidence of AMR in the country. So what we did was we took our decaf genomics cohort, 6 centers in the U.S., 6 centers, 5 in the U.S., and those 5 centers, they had transplanted between 2005 to 2011. I showed you all their data on the 194, but then we said, okay, which of these have claims data? And we were left with 175 AMR patients and 2,655 with no AMR, and we found claims for them in USRDS. So the beauty of USRDS is that it has CPT codes for kidney biopsy. It even has a diagnosis code on that biopsy. And it also captures treatments of IVIG, plasmapheresis, rituximab, bortezomib. These were the treatments that were available during this time period. And this is the publication that we published in Journal of Medical Economics in 2021 that describes these claims data. So we looked at our algorithm. We tried several algorithms, so I'll describe a few of those to you. Decaf patient with a kidney biopsy claim with any treatment claim within 60 days of the biopsy. So we found those claims, and what we saw was, looking at our cohort, we found that we had a 39.4% true positive or rate or sensitivity of 39.4%. The false positive rate was 4.1%, so about 95.9% specificity. So if you didn't have a claim for a biopsy and any treatment within those 60 days, you can be reassured, the specificity is good. You can say, okay, they did not have an AMR. But as you can see, the sensitivity is quite poor. So we tried different algorithms to see if we can bring the sensitivity up. So we said, okay, what if we forget the biopsy date? We just looked at, allow for any biopsies, and we weren't tied to the 60 days of, after biopsy treatment. We increased our true positive rate by 50%, but then reduced the false positive rate by 21%. So we also looked at the next algorithm. We looked at the rejection diagnosis code. Unfortunately, that was not helpful. Up to 175 AMRs with claims, only 86 had a rejection code. So obviously, they were coding for other things that were going on at that time, and rejection wasn't one of the things that stood out. So of those 86, only 64 had treatment to claims within that 60 days. So we were really left with 35% true positive rate and 4% false positive rate, even when using these combination of rejection codes. So we said, what if we just use a rejection code or a biopsy code, and brought the true positive up a little bit, 42.3%, but the false positive also went up to 5.4. So in the end, we were not satisfied with finding AMR using claims data. So I'm switching gears now. So what do we do at my center? How do we try to capture CMR before it's too late? At my center, we do regular follow-up of creatinine and proteinuria. At our center, all our patients have to get a creatinine every month, regardless of where they end up. They could be across the country. They have to send us that creatinine data, and the coordinators are looking for it. We do a fair amount of monitoring of trough levels of CNI. We don't measure the interpatient variability of these trough CNIs or interpatient, but our pharmacists are quite involved in looking at these, and the hope is that if they see someone has erratic levels, then it sort of sends a signal that maybe something is going on. We also, at our center, do abbreviated AUCs of MPA for cause. So we ask our patients to hang around for 2 hours, and we draw blood draws at 30 minutes and 1 hour and 2 hours, and do these AUCs if we're concerned about something. I know most centers don't do that abbreviated AUC, but we do. So the hope is that in the future, we have some smart EMRs that can alert us to changes in creatinine, in proteinuria, and IPV, interpatient variability of CNI troughs. Because if you talk to our pharmacists, our pharmacology colleagues, they will tell you the interpatient variability of these trough levels is predictive of bad outcomes. All right, so I'm going to conclude here. The incidence of CMR, unfortunately, is not captured well in the claims data, as I've shown you. Electronic medical records can assess incidence, though we do need biopsies to be coded as CMR. So as you saw in our DCAF study at that time, we weren't coding, we were just coding everything as AMR. We weren't going as chronic antibody-mediated rejection. So even in our data set from DCAF genomics, we can't tell you the true incidence of CAMR. So I guess the answer to the question is, do we really know? I would probably say we're not sure yet. If you look at the risk factors for AMR, younger recipient age, more HLA-DR mismatches, higher PRA, B or T cell cross-match at the time of transplant, and delayed graft function. These were risk factors. And the hope is that with close follow-up of creatinine, proteinuria, and immunosuppression levels, we can at least risk stratify patients and biopsy them early and often if for any increase in creatinine or proteinuria. And hopefully we can get to the true answer of what's the true incidence of CAMR. Okay, just wanted to thank all the sites in DCAF Genomics and the coordinators that really helped us get all the data, and our statisticians that pulled us together. Dr. Hart was the first author on those 2 manuscripts that I mentioned, this has kind of been a long-standing project of our group, and hopefully we'll try to get more answers for you in the future. Thank you.
I think in keeping the format of the main meeting, we'll have our 3 talks, and then hold questions for the end for 30 minutes at the end. Again, we didn't introduce ourselves. I'm Deb Beatty from UCSF.
And at Tambor Northwestern.
So on that note, we'll introduce our next speaker, Carrie Shinstock from Mayo Clinic.
Thank you. So let's go. I'm not able to advance these slides. Oh, there we go. Okay, so I'm going to talk about the tools that we have to treat antibody-mediated rejection. Are they the right ones? I do have some financial disclosures. I have research support from CSL Behring, Hansa, and Sanofi, and I am going to talk about some off-label use of medications. So what am I going to talk about today? First, I'm going to describe our current criteria for antibody-mediated rejection. I'll outline a practical approach to treating these patients and then summarize the data that's available for the recommended treatments. Okay, so from a very basic level, how do you make the diagnosis of antibody-mediated rejection? Well, this starts out with a biopsy, and our diagnosis of ABMR is based on the Banff classification. So if you look at the most recent classification that's published from 2019, you need to meet 3 separate criteria to actually make that diagnosis. One, you need some histologic evidence of tissue injury. This can be inflammation, typically microvascular inflammation, inflammation in the capillaries or the glomerular capillaries, peritubular capillaries, but this can also be thrombotic microangiopathy or even acute tubular necrosis or ATN. 2, you need some evidence that the antibody is actually interacting with the endothelium. This is either with that microvascular inflammation, or it can be C4D positivity, or some indication that there's complement activation. And number 3, you need serologic evidence for donor-specific antibodies. So the current criteria to make a diagnosis of ABMR, you need to meet these 3 criteria. And note that if you have microvascular inflammation, that meets your first 2 criteria. Okay. What about chronic antibody-mediated rejection? We talk a lot about that. What is that? It has nothing to do with the timing. It has nothing to do with the creatinine or the protein. It all has to do with the biopsy. So you need to meet those 3 criteria for the active ABMR that I went through, and then you need some features of chronicity on that biopsy. And I'm showing you a picture of that here. The arrow is pointing to this double contouring of the glomerular capillaries. That's your transplant glomerulopathy, chronic glomerulopathy. So active ABMR plus chronic glomerulopathy gives you a chronic active antibody-mediated rejection. So that seems like a nice histologic classification, right? But I want to point out that not all ABMR is the same, not one size fits all. So first you have to recognize that antibody-mediated rejection, specifically chronic antibody-mediated rejection, is a spectrum of injury. And there's varying degrees of chronicity and also varying degrees of activity. And if you look closely at those Banff scores that your pathologist hopefully gives you, it will give you an indication that these biopsies can really look very different based on the amount of chronicity and the amount of activity. The other thing that I think is critically important in this space is to recognize that the biopsy can look the same, but you have probably very different things happening from a mechanistic standpoint. And I look for Dr. Chong to talk to us more about that. But you can have patients who've had antibody at the time of transplant, and then you can have patients who develop antibody late. There's also difference in the timing. So we talk a lot about these patients who have a positive cross-match DSA at the time of transplant. Within the first 30 days, usually the first 2 weeks after transplant, you see this abrupt increase in their antibodies, abrupt increase in creatinine. The C4D is definitely positive on that biopsy. This is an early active antibody-mediated rejection. And then you have these later forms. And these can occur in patients who have pre-transplant DSA. Maybe they missed out on that early point, but you've done surveillance and you see that they have some antibody-mediated rejection later, or you have patients with new antibodies or de novo antibody-mediated, de novo donor-specific antibody. It's important to know that the biopsy is going to look a little different just based on when you did the biopsy. If you do it very early, you'll only have if you do it early, you'll only have those active features. But if you do it late, you'll start to see that transplant glomerulopathy. So what you have really depends on when you did the biopsy. Also, in these cases, C4D may or may not be positive. That doesn't affect what it is, but there is some variation there. So varied mechanisms, likely these patients need some different treatment strategies. So with that in mind, how should we treat these patients? Okay. So what is the data out there? I could spend a lot of time going through the individual studies that have been published, but I think it really is summed up nicely from this meta-analysis that was published in 2018. And they looked at over 14,000 citations, and they ended up with 21 studies. Of these, only 10 of them were randomized controlled trials, and they looked at 750 patients. And this was the main points. One, they only had enough data to do a pooled analysis for antibody depleting therapies, so really not good data. The studies were extremely heterogeneous. They were all over the place in how the patients were treated, what kind of ABMR were included, whatnot. Rituximab has little to no benefit, that's what they found, and there's really insufficient data for bortezomib or complement inhibitors. And to be honest, what they really found is that in practice, people are using a lot of different things, but there's not really data to support that. So with that backdrop, specifically these heterogeneous treatment strategies, a working group was formed by the Transplantation Society. And we met back in 2019. We reviewed all of the studies that were available and the mechanisms behind, and really tried to come up with a treatment strategy with the goal of making our treatments more uniform. And in my mind, one of the accomplishments of this working group was really to define these different phenotypes as a framework when we think about treatment. So I'm going to talk about treatment in the context of this framework. So I'm going to start out with these patients who have the pre-transplant DSA and have a very early antibody-mediated rejection. So what do you do here? Again, these are patients who have an aggressive antibody-mediated rejection. Most of us don't see this in practice very often. We avoid DSA because of our great testing. But if you do have a patient with this, our working group recommended plasmapheresis, IVIG, and corticosteroids, and recognize the data supporting that is a grade 1C in expert opinion. Now, you could consider other therapies, eculizumab, rituximab, splenectomy, but as you can see, the data supporting those therapies is limited. So what about these later antibody-mediated rejections? I'm going to go into the treatment approach for these various phenotypes. So first, what about those patients who had some pre-transplant DSA or non-immunologically immune? They had early DSA, and you detect this ABMR later than 30 days, usually on a surveillance biopsy, but it could be later when you're noticing the creatinine is high. And our working group felt that if the BAMF score was 0, meaning they didn't have any of the chronic features, just those very early features of activity, that it was reasonable to consider plasmapheresis and IVIG because this was fairly early. But the key point is we didn't really recommend any of these therapies if there was any degree of chronicity on this biopsy, an important point. Okay, So what about those patients that have new DSA or de novo donor-specific antibody? What do we do with those? And to be honest with you, in practice, in the community, these are the patients that we typically see. So our group, again, together, what we recommended was that the goal should be to really optimize their immunosuppression, okay? They likely developed this de novo donor-specific antibody with reduced immunosuppression, so let's optimize that. Evaluate their non-adherence, and if there's any concomitant TCMR, to address that and to treat that. You could consider plasmapheresis or rituximab. I think those were considerations, but notice the data supporting that is like really not there. It's really low-quality data. So the main points from that are, one, I hope that now when you see a patient with ABMR, you're able to kind of put those patients into the different categories, recognize that your treatment strategy should vary, and really, ABMR in the context of new or de novo donor-specific antibody, really treat maybe their TCMR and address their non-adherence, but less treatment may be more. There's not really data supporting Ritux and plasmapheresis and all of the aggressive treatments that are often used. Now, that part of the talk could have been quite depressing, right? What did here, let's treat this, but there's nothing that works. So I can't end with that. So we're going to also talk about some novel things that are available. Despite that, it is an exciting time. There are some new things that are available. So here's a list of the therapies that are being looked at. For the sake of time, I can't address them all, but there are a few that I'm going to talk about. So I'm going to focus on IL-6 inhibitors, the IgG endopeptidase, these inhibitors against the neonatal FC receptor, and also anti-CD38. So we'll talk about IL-6. IL-6 is an important cytokine throughout the body. It's an essential mediator of inflammation. And in a single center study of 36 patients out of Cedars-Sinai, they used tocilizumab. Tocilizumab is an IL-6 receptor blocker. They used this in patients who were refractory to these other therapies. And they found that this led to this stabilization in their GFR, and this is over 3 years. They also found that this treatment was associated with a reduction in microvascular inflammation and reduced C4D deposition. But one of the problems that they found in this study is when they stopped the drug, there was probably rebound. Patients got worse really quickly. And the thought was that because this was blocking the IL-6 receptor, when you blocked it, there was more receptors, so you had all of this IL-6 activity. And so investigators began to look at other IL-6 inhibitors, specifically clazakizumab. This acts a little differently. Instead of blocking the receptor, it's actually a direct inhibitor of IL-6. There's decreased rebound of IL-6 with the discontinuation. And in fact, this particular agent was looked at in a randomized controlled trial of 20 patients, 10 to claza and 10 to placebo, and they did see this stabilization in GFR in the claza treated in this small phase 2 pilot study. And because of these promising results, now there's a phase 3 trial that is ongoing, recruiting patients, and they're looking to recruit 350 patients. So that's recruiting now, excited about the results of that study. So what about imlifidase or ITIS? This is also another exciting agent. What it does, it's a cysteine protease that cleaves IgG in the Fab and FC fragment. And in desensitization studies, they found it was quite effective. You see here in about half an hour, you see this dramatic reduction. Within 4 hours, you can't even find the antibody. It only reduces IgG, so has no effect on IgM. There can also be a rebound from this agent. The other problem is that there's some anti-itis antibodies that can form, so you can't repeatedly give it. I mean, it'd be nice, right? It's like plasmapheresis in a bottle, but you can't repeatedly give it. So this agent is exciting, but it'll likely be used in combination with other things. So what about targeting the plasma cell? We know that the plasma cell is important in this space because it's constitutively always secreting these antibodies. And we know that plasma cells are CD38 positive. In the multiple myeloma world, there's excitement about daratumumab. They're using this as treatment, and it makes sense to try this in the ABMR world. And this is a case report, actually, where they used daratumumab. And like with some of the other agents, they saw a stabilization in GFR with using that. Again, this is preliminary. It's to generate excitement. So there are potential agents available. And lastly, what about this FC neonatal receptor? And this is, I'm going to butcher this name, but rosnilimab is one of these agents that has been used to block this receptor, and giving this has also shown a reduction in IgG. So for those of you who aren't aware, this neonatal FC receptor is really important for the recycling of IgG and keeps it in the circulation. And there's some data to suggest if you block that, you have less of that antibody available. So again, new agents, more to come in the future. So in summary, ABMR represents this spectrum of injury. There's varied phenotypes. We need to think about with these varied phenotypes, there's likely varied mechanisms and a lot of new novel agents in the pipeline. So there's really an exciting time. And I look forward to hearing Dr. Chong's talk, because she's going to talk more about the mechanisms.
Thank you, Kiri. Our next speaker is Dr. Anita Chong from the University of Chicago.
Thanks, Annette. Thank you to the organizers for this invitation to speak here today. Okay. So I have no relevant financial disclosures, although I have to let you know that I'm a mouse immunologist, and so where you are and where I am, there is kind of a little bit of a gap. But I will be discussing some off-label use of drugs. Okay, so the overview of my talk, I was asked to address 3 questions. The first is to assess the deficiencies of current treatments of chronic AMR, and because I still want to have friendly colleagues, what I'm going to do is not really address the deficiencies, but actually provide a conceptual framework from a scientific, from a scientist's point of view of how to assess these mechanism-based therapeutic approach, so to propose a way to develop a mechanism approach, therapeutic approach. The second is that I'm going to describe some novel therapies and proposed mechanism of action within this conceptual framework. Primarily, you can imagine targeting the immunological processes as well as targeting the tissue remodeling. But because I'm an immunologist, I'm going to mostly focus on the immunological targeting. And then thirdly, I was asked to sort of speculate on how the transplant community can collectively tackle this problem. And I, from a basic science, a lot of that work has come from the bench to a bedside type approach. But I feel that now, with all these omics approach, I think now is a good time to consider taking a lot of these findings that you guys are seeing in the clinic and trying to bring it back into the bench to really understand mechanisms and really be able to identify better therapies. So, with that, the conceptual framework. So this is taken from a very recent review by a colleague at the University of Chicago, Bana Jabri, and I thought that it was really a nice way to look at chronic AMR. And basically what we're proposing is that in every individual that is healthy, there is kind of a baseline, immunological healthy state. And that this state can accommodate acute insults. And so the insults, whether in our case, the presence of an alloantigen or pro-inflammatory signals, and that this response, this immunological response, can result in some immunological damage, but that there is an elasticity elasticity to this healthy state. And so after this response is cleared, the immune response and the tissue goes back to its original healthy state. But that there are instances in which either that insult is so large or that the insult is not completely resolved, so that you have a chronicity and a repeated damage. And this, over time, results in a change in this healthy state. So it sort of you lose this elasticity potential, this resilience, and then you move to a different state that we call, this chronic, and in this case, chronic AMR state. And this state now is marked with immunological and tissue scars. And some examples of these tissue scars in terms of the immune cells is that now you have tissue-resident memory cells, B cells, T cells in that tissue. We have long-lived plasma cells that make antibodies spontaneously and independent of antigen signaling. And perhaps there is also a loss of these wound-healing immune subsets, innate subsets. And then in addition, you could also have anatomic scars, so that there is tissue remodeling, so that now, even if you remove some of these ongoing pro-inflammatory signals, you are going to return to a slightly different state, or a significantly different state than the original healthy state. And some of this is manifest by epigenetic changes within the immune cells as well as the tissue cells, so that now there is a predisposition towards response to inflammation. So again, the triggers to trigger the inflammation will be very different from the triggers of inflammation that that characterize the original early plasticity and return to a healthy state. And so the next thing I want to do is to just focus a little bit more, or discuss a little bit more about what these immunological scars could be that lead to chronic AMR. And so in the initial reversible acute phase, where acute donor-specific antibodies are being produced, we all know a lot about this process. It's T-cell dependent. This T-cell dependent activation of the B cells generates large numbers of these short-lived antibody-secreting cells. And that when you interfere with this T-B cell activation, the antibody secreting cells that are short-lived, just spontaneously clear, and so the antibody response, goes down, and that the acute endothelial cell damage and the acute antibody-mediated rejection, resolves, and you return to this healthy state. And we know, all of us know, that there are many things within your clinical toolbox that allows this acute antibody-mediated process to be reversed. Steroids, anti-B cell therapies, anti-T cell therapies, anti-proliferative agents, anti-complement, and co-stimulation blockade. So then when you when you sort of switch over to this new homeostatic chronic phase, now, at least for AMR, you have now cells that are producing antibodies that are independent of antigen. And these are these long-lived plasma cells that reside in the bone marrow, in your tertiary lymphoid organs, and in the tissues itself. You can also have chronic tissue inflammation that is occurring in situ in your graft, and this ultimately results in tissue remodeling. And so one can imagine that in this chronic phase, you need to add reagents such as those that target these long-lived plasma cells, and perhaps consider better versions of plasmapheresis or IDs that result in long-term, or at least short-term IgG removal. And then for chronic inflammation, as Dr. Shinchak has discussed, reagents targeting cytokine receptors. So generally, targeting molecules that drive tissue inflammation and remodeling. And so the next part of my talk was to try and discuss some of the novel therapies and mechanisms of action, and many of them had already been discussed by Dr. Shinchak. But I want to discuss this type of novel therapies in this conceptual framework. And so one of the targeting approach that my lab in collaboration with Ron Pelletier and Marlena Habal, has been working on, as well independently by the Connectly Quan Labs, is this idea of dual targeting to prevent or reverse antibody responses. And this is a combination of using co-stimulation blockade and something that targets the plasma cell. And in our case, we're using proteasome inhibitor. And certainly you can use an anti-CD38, a Dura something, to target the cells. And so if you see donor-specific antibodies in a transplant recipient, then you know that the cell if you can target the cell that's producing this antibody, whether it's a short-lived antibody-secreting cell or long-lived plasma cell, you want to do that, and you can use, in our case, a proteasome inhibitor. But in a recipient that has the antigen, the graft still in that person, it's highly likely that these antigens are continually going to drive the process that results in the generation of more antibody-secreting cells. And so if you deplete just the antibody-secreting cells and not the upstream events, all you're going to do is just drive new cells. And so you're caught in this continuous need to give proteasome inhibitor, which is just not sustainable. And so what we thought was that we understand a lot about this process that results in the generation of antibody-secreting cells. And this is through the use of, in our case, a co-stimulation blockade that we already knew would block this initial T-cell, B-cell interaction, as well as T-cell becoming activated and differentiating into these T follicular helper cells. My lab went on to show that CTLA-4 Ig that blocks CD28 B7 interactions occurs in the germinal center. And so if you have a germinal center response and you start treatment with BALA in this case, you can actually dissolve the germinal center response. We also went on to show that if you already have memory cells and then you re-stimulate the memory cells to differentiate into antibody-secreting cells, again, BALA or CTLA-4 Ig can inhibit this process. And so all the upstream events leading to antibody secretion can be inhibited with CTLA-4 Ig. And so we showed this work first in a mouse model where we delayed treatment with CTLA-4 Ig and the proteasome inhibitor bortezomib, and show that in a mouse that's fully sensitized with a skin graft, delayed treatment with this combination can reduce the levels of circulating donor-specific antibodies. And then we went on to show with Ron Pelletier went on to show in a small series of proof of principles studies that 5 out of 5 acute AMR could be reversed with this dual treatment, and 2 out of 2 patients with established AMR starting treatment pretty late after a transplant was also successful. But more impressively is that Marlena Habal, who went on to show that this same protocol could be used to desensitize highly sensitized heart transplant candidates with this combination of belatacept and proteasome inhibitor, in which 4 out of 4 patients were successfully desensitized, and 3 out of the 4 went on to receive a heart transplant. And one of the advantages that maybe not all of you know is that co-stimulation blockade has an extra special effect, is that, and it was shown by Rosansky et al. At 2011, that long-lived plasma cells, those very special long-lived plasma cells, actually express CD28 and require CD28 for its survival. And this was then confirmed by Halili et al. For human long-lived plasma cells, that they express CD28. And this basic science finding actually predicted and was the explanation for the findings by Bray et al. And Parsons et al. That post-transplant reduction of pre-existing DSA as well as third-party HLA antibodies were observed in patients treated with belatacept. So we already know now that there is enough data suggesting that this is a really promising approach for treatment of acute AMR and desensitization. And so the question now for all of us is whether this approach will be effective for chronic AMR. And so a little bit about novel targets, and again, Dr. Shinstock had alluded to discuss this FcRn, this neonatal Fc receptor that contributes to this very long half-life of circulating IgG. And there are two drugs out there that are targeting this FcRn, and this approach might be a gentler, more sustainable way to reduce circulating IgG in the context of chronic AMR. And I think that there are also basic findings by the Fairchild, Baldwin, Reed labs looking at the chemokines and the cytokines in the cells that are mediating actually the injury as a result of antibodies. And I think that these types of findings offer new opportunities for targeting. So then the last is, how do we, as a transplant community, tackle the problem of chronic AMR? And I think that now is the time to really start focusing on bench-to-bedside approaches, and so that we can go from correlational data, even though if they're really good, to really mechanistic studies and provide a rationale, a mechanistic rationale for why we're using certain approaches, certain drugs, and when we should use them. And I'm only going to, of course, highlight one of the studies from my lab together with, that was in collaboration with the Clark Lab and the University of Chicago Transplant Institute. And this was to identify a potential role for non-HLA and autoreactive antibodies. And one of the things that sort of drove this study was this finding that about 30% or 40% of the biopsies in the University of Chicago transplant program for kidney transplants are diagnosed with chronic AMR. But the majority of these patients do not have circulating DSA. And so one of the questions we wanted to test was, is there in situ DSA production that is causing, but it's just not enough to be detected in the circulation. And so the way that we did it was to define the specificities of the B cells and the plasma cells that were infiltrating these kidney biopsies. And we sort of expressed the antibodies that were produced from 105 B cells from 7 biopsies, and we found no B cell produced donor-specific MHC. But what we did found was an enrichment for B cells that produce non-HLA autoreactive antibodies, and that these B cells were innate-like. And so what we have done so far is to generate a mouse model and try and start looking at the incidence of autoreactive antibodies. And what we're finding is that if we do a syngeneic transplant, there is no DSA, there is no autoantibodies. In a fully allogeneic, unmodified rejection, you see both DSA and both autoreactive antibodies. But if you treat it with CTLA-4 Ig, you can block donor-specific antibody production, but not the autoreactive antibodies. And so this mouse model now lets us start asking really, mechanistic questions. What are the specificities of these other antibodies? What are they really pathogenic? And what is the type of pathogenicity they have? And how do we go about reversing these autoantibody production, since it seems to be dependent on different signals as donor-specific antibodies? And so such studies require a whole, I think, village. And so the human studies on B cells were led by my collaborator, Marcus Clark, and a really talented PhD student, Yuta Asano. Our DSA assessment was done by a postdoc in my lab with advice from Dr. Tambor. And the clinical studies I mentioned were led by Ron Pelletier, who's now in Rutgers, and Dr. Habal, who's now in NYU. And the mouse studies were done by various members in my lab at the University of Chicago. So I thank you for your attention, and we'll take questions in the discussion.
Thank you so much, Anita. We're going to open this for discussion. We had 3 amazing speakers. I just cannot resist, AJ, to ask you, you mentioned HLA-DR in your studies, and as the DQ person, can you please set the record straight?
Yes, unfortunately, we did not have good data on DQ, so that's probably the limitation of our data set.
Yeah. All right, so maybe I'll start with more questions until we have some more from the audience. I'll move to you, Carrie. We talked about a lot of studies that are looking at the potential of different drugs and so on and so forth. And again, coming from the antibody side, I think one of the limitations is we're sometimes comparing apples to oranges. So how would you recommend us to proceed with trying to figure out what are we treating? I'm referring to how much antibody, but anything else that you want to add to that?
No, I think that's a great point. I think this means the community needs to get together and have some minimal standards of when we have a paper of how we are talking about if they have DSA. Also, we need to, from a basic perspective of quantity of antibody, we know that the MFI in these patients is really unreliable. So thinking about having a standard way of doing dilutions or reporting dilutions would help in this space as well, because I agree. There's differences and there's also differences of expression of the HLA antigen on the cells that we haven't even explored either. But we could start out with, as a community, having some minimal standards about what we at least report in these patients.
So I'll put my star hat for a minute, and this is, for those of you who hadn't seen the new reports, this is really one of the recommendations that we're bringing to the field. I think it's going to be really critical for us in order to then compare between studies.
Yeah, hi. I'm Behring, Emeritus Chief of Behring, University Medical Center Transplant Programs. Having done kidney transplantations in 1978, liver transplantations since 1979, involved virtually every new immunosuppressant developed ever since. Thank you. And I'm now retired. But just before I was retiring the last few years, I was actually focusing on AMR, and primarily liver AMR. AMR is a biological issue. It doesn't really matter what the antigen is, if it's a kidney or if it's a liver. I'm just going to share what I did a little bit with the basics. Number one, when I found an AMR, and I actually reviewed virtually every single biopsy myself together with picked out, selected pathologists, because that's one of the issues with these studies, that you don't have good enough pathologists. So the first thing I did was I started plasmapheresis to get rid of the antibodies. And I gave them rituximab and bortezomib to get rid of some of the producers of these antibodies. And then I started doing something that actually was frankly revolutionary. And I think actually with all my involvement in the development of cyclosporin and the development of tacrolimus and sirolimus and the rest of them, I have to say, maybe the most impressive drug I've ever used after the introduction of calcineurin inhibitor is actually belatacept. And I could actually, with the plasmapheresis and the rituximab and Velcade, I could actually stop the acute rejection going on, or AMR. I could actually hold that, but then adding the belatacept, eventually I ended up actually stopping all other maintenance immunosuppression, and these patients are years out, and they have no side effects of any kind. You can take that home and think about it. I think belatacept has a potential role here that is way beyond anything else. The belatacept trial failed because, and I'm not going to go into too embarrassing details, but it was actually a company developed by a company who had no background in transplant, and they made the selection of the sites, worldwide sites, and they didn't care about the experience and expertise in transplant. They just want to have sites that actually they thought they could talk with and have control over. So we had massive problems with the sites in that particular trial. So that's why that trial failed because we couldn't get, well, I'm not going to go into details. I reviewed virtually every single patient, and if I had any patient treated like that at Baylor, I would actually fire all the people who were involved in that case. I'm not talking about worldwide now. So anyway, back to belatacept. I started using that again, sort of outside all the regular stuff, and this was no formal trial. FDA was not involved because then nothing happens. So I would just bring that up, and I want people to think about this. So when you have an AMR, reduce the antibody level, get rid of the cells producing antibodies, and then put in a CTLA-4 inhibitor. And then I think actually we may have a whole new treatment algorithm, not just for the AMR, but actually for long-term maintenance of all organ. Actually, some of this has been published. So, but it's not formal studies, so people are probably not looking too critically at that. Thank you.
Thank you for those insights on belatacept. And Anita, that sounds promising. We're a huge belatacept center, and I didn't know anything about this. Do you know of any trials? Carrie, do you know of any trials coming up using belatacept to treat acute AMR?
Good question. I'm not aware of any. There are some retrospective studies looking at using belatacept in chronic antibody-mediated rejection, but they have been mainly retrospective studies. They haven't been prospective, but I also have interest in belatacept in some of these patients because we have to study it.
Yeah.
Right? And I think it's hard. The problem is it's hard to study these.
It is
hard to
hard
study things.
because criteria vary. Is there another question?
6 and 7 years out and have normal liver function. Follow-up likely shows some stable, inactive fibrosis in some areas of the liver biopsies, but there's actually no activity, and the liver function tests are normal. Take that home.
I just have 2 questions. Thanks for the presentations. They're very good. One question, looking at causes of chronic antibody-mediated rejection. Have there been any studies looking at the impact of going to lower doses of chronic immunosuppression to see whether that may have caused it? So just if you could, so it'd be interested to hear your thoughts on that, because this is just one perspective. A lot of times the patients blame, but I wonder if it's also maybe because of the change in medication dosage. So just interested to hear on that. And then the second thing is that showing that this is such a big issue, I don't really see much education of the patient community on this subject. And because of that lack of education, I was just wondering if you had any comments about to maybe improve that. So anyway.
I want to add one thing to that statement, and then somebody could please address it. One of my big concerns is the patients that get referred back out to the community, and the other physicians who are not as transplant trained don't really understand it that well, reduce immunosuppression for a variety of reasons.
Right.
And then we get called maybe down the road, gee, I don't know why they've got so much protein in their urine. So if anybody has thoughts about that, this is one of those things that really kind of gnaws at me.
Do you want to say anything?
Yeah, I think that there's still the notion that, as you go further down from the transplant period, you need less and less immunosuppression. I think that's kind of what the thinking was maybe a decade ago or so, and I think that still persists in the community. I think that's why we see reductions happening when patients are not being followed up at the transplant center.
No, but I think the point is that this isn't all the patient. A lot of it is us. Yeah. We're doing it for BK, we're doing it for CMV, and now with some of these non-invasive biomarkers, these are great for surveillance and see how you do, reduce the immunosuppression until there's signals of rejection. One of the problems I see is that, especially with ABMR, is once this happens, you're stuck. I mean, you can't go back.
Yeah,
at
cat's
least,
out of the bag.
At least in the current environment with our therapies that are available. But the point is, a lot of it's us as providers.
And it's not, this is just a thought, just take it for what it's worth. I appreciate the acknowledgement, but that self-awareness is not universal, and there's patient blaming when it's a change in protocol and lack of follow-up by the community nephrologist. So I think in that bias has lots of implications in terms of patient care. So I just would ask you to counter that dogma that's out there. And then the second thing is that if this is such an emerging issue, right, we know it's a big issue, I think there's a huge deficit in patient awareness on this subject. And I'll give you a case in point. I did a meeting with a patient support group and asked them what chronic antibody-mediated rejection was. Not one patient out of 15 knew what the topic was. So anyway.
More thoughts on this?
Just an observation and a suggestion. Thank you.
So one of the problems that Ajay, you've pointed out is the fact that we really don't have a good way to capture what is the prevalence or incidence. Any more thoughts other than what people can do in their own individual centers, how to try to capture this at the more national level?
Yeah, I think we can also look at other national studies that are going on. Like right now, Apollo is ongoing, and they're collecting biopsies and stuff. So there might be some secondary uses of their data that might inform us in the future.
Can we add to this a tag to educate the patient so they're aware that if something like this happens, they need to go back to their regional centers and not just rely on their community nephrologist? Not to hurt anyone's feelings, but
Yeah, no, I think that's a valid point that was made, that we're not educating our patients well enough about possibility of antibody-mediated rejections.
The other thing to recognize is that in the early forms, usually, especially in chronic antibody-mediated rejection, if this is slowly progressive, a lot of times the creatinine is going to be stable, the protein is going to be stable, you won't see a change. And so without actually doing a biopsy on these patients and seeing what's going on, by the time they have a change in function and protein, they're pretty advanced. And so, I just put a plug in to actually seeing the tissue there's still a lot of value in that, from my perspective at least.
maybe a little bit of a provocative question to you, Anita. Not to put you as a clinician on the spot, but you were showing us that really when you go into the chronic ABMR treatment, if you're using a lot of the more common strategies like plasmapheresis and so on and so forth, you're actually exacerbating the problem. Did I understand that correctly? And if that is the case, then should we figure out a way to realize this sooner and use different approaches?
Well, I can't say that it would make it worse, but I think that some of the therapies that are very effective for controlling and reversing acute processes may be much less effective in the later phases because their role in which they're playing in driving chronic rejection is less because other later players become more prominent. And I think that a clear example is that you're moving from this generation, the continual generation of these short-lived plasma cells, and much of your antibodies are now going to be produced by these longer-lived plasma cells that are less T-cell dependent, right? And so the processes of co-stimulation blockade will be less effective, immediately effective with this different population. And I think that the other thing is that a lot of the early processes are going on in your secondary lymphoid structures, so in the lymph nodes in the spleen, but that maybe later on, a lot of these tertiary lymphoid structures that get set up in your allograft itself, and the inflammatory signals that drive the tertiary lymphoid structures may be somewhat different. And so if you go back to the original one and then you don't see that effect, it's not that they're not working, it's just that those processes are not driving the chronic rejection. And so what I was trying to propose is that if you have a mechanistic framework, then what you plug and play, makes sense to you, and that one one plug doesn't work equally throughout the process of chronic rejection, right? If you catch them early, its dependence on acute, its resilience, its ability to spring back to its healthy state is still preserved. But if you catch it really late, then what you consider success is going to be very different. And I also want to say that, you know, a single drug is highly unlikely because it's already late, so many things have happened, right? And each might be dysregulated in slightly different ways. And so I think tackling that problem is a lot harder. And getting good quality data, I think it's a lot harder.
Any other questions? And I think yes, please.
Thank you for an interesting talk. Speaking from an infectious diseases perspective, I just want to say that the comment about blaming patients resonated with me. I do see that in the charts, not unusually in patients with chronic rejection. I wanted to highlight the comment that often patients have infections, CMV and BK, the MMF is stopped or cut in half, and then it's never restored to previous levels. I do think that's something that we can do better as a society, and maybe it behooves us in infectious diseases to come up with some guidelines, not just about when to reduce immunosuppression, but when to restart it. And maybe if we had better, antigen-specific antibody markers for infection, perhaps we could do a better job of saying when does the patient recover their anti-BK or anti-CMV immunity sufficiently so that they can go back on full-strength immunosuppression. I also wanted to say that although the data about some of these IL-6 inhibitors is definitely encouraging, I'm interested to know about potential infectious complications. A lot of times these new drugs are tested in animals and primate models for the safety record in rheumatology. Or the safety information comes from rheumatology where drugs are used in monotherapy. And I feel that in the setting of triple immunosuppression, when you add on not just an IL-6 inhibitor, but a chronic IL-6 inhibitor, it makes me a little bit concerned. Thank you. Sorry.
So just wanted to suggest that we need to incorporate some concern about infectious complications of these new antibody-mediated rejection and chronic antibody-mediated rejection treatments, especially if they're going to have long-term effects immunologically.
No, you're absolutely right. And I think your proposal for some guidelines on managing immunosuppression post-infection, post-malignancy would be a great collaborative project, putting a plug in for IDCOP and the KPCOP to work together to come up with something. I don't know who's in here from KPCOP, but I think that would be a great collaborative proposal.
I just want to add to that same point that I know that at least in several centers, when the ID guys are recommending to lower immunosuppression, the first thing that comes up as a consequence of this is starting to monitor antibodies more frequently. So you're able to kind of get the cat as it's going out of the sack rather than when you have all the consequences. So maybe as you guys are working on this, if the HLA community can help with some input.
Yeah, that would be.
I think the larger question, I think this is a great point. The larger question is we don't know how to personalize immunosuppression because some patients don't need their immunosuppression up, and we don't know, right? In fact, I mean, our patients are dying of infection and malignancy. And so that, I think the larger picture is really knowing how much immunosuppression people need.
Any other questions? I think this has been a great session. I mean, the chronic AMR is just such a dismal diagnosis and, major loss of allograft in the long run for most of our patients. And it's a little bit of a flicker of hope that maybe there are some therapies on the horizon that maybe we can at least mediate this a bit. So I think these are all three great talks.
Yep. I think we'll thank the speaker and the audience for a wonderful session.
Unless
Thank
there's
you.
any last questions. Okay, thank you all for attending.
I think I really